Yes, ma'am, you can start now.
Okay, sure. Over to you, Dr. Meenal.
Thank you. A very good evening, everyone, respected faculty and distinguished delegates. On behalf of entire Gennova team, I, Dr. Meenal Bhagwati, the Medical Deputy Manager for CNS Cluster, extends a very warm welcome to you all on this platform to our No Thrombosis National Workshop. This initiative is based on case-based insights on stroke care, which focus basically on real-world clinical challenges. Well, through this shared clinical experiences and expertise, discussion and education, we aim to deepen our knowledge and understanding towards the stroke management on everyday basis. So, without further delay, I would like to introduce our focus director and also the moderator for today's session, Dr. Rupesh Bogde, who is a consultant and head emergency medicine and trauma in Kingsway Hospital, Nagpur. He has more than 10 years of experience in critical care and emergency specialty and holding his DNB and IDCCM and MRCEM UK qualification. He is certified instructor for AHA and ACS and serves as an international examiner for the MRCEM UK examination. His extensive clinical expertise in managing high acuity emergencies and including trauma, cardiac, pediatric, and also critical care cases. Apart from clinical, he is also active academic contributor for multiple publications in indexed PubMed journals and authorship of chapters in reputed EM and critical care textbooks. He is a regular faculty and speaker at national and international conferences and trainer in workshops. Currently, he is associated with Kingsway Hospital as an consultant and head emergency medicine and trauma, and previously held leadership role at Wokhad and Alexis hospitals. His key interests include emergency medicine, critical care, trauma, resuscitation, acute cardiac neuro emergencies, and medical education and training. I welcome you, Dr. Rupesh, to this platform.
Hello everyone. So I think thanks for the introduction. So can you introduce our next speaker also, Dr.
Yeah.
Niranjan Minal?
Yeah, sure, sir. So moving towards our next speaker, Dr. V. Niranjani. She is a consultant and head in Accident and Emergency Max Super Specialty Hospital, Nagpur. She is a senior emergency medicine specialist leading accident and emergency services with expertise in managing high acuity clinical situations. She is certified AHA instructor and ATLS instructor, faculty and site director for MEM, actively involved in training DNB residents in medicine and anesthesia. She has a core expertise includes resuscitation, cardiac and neurological emergencies, sepsis and shock management, and hemodynamic monitoring. She is active academic contributor and publication in Index Journal and experience as an academic guide. Also organizing chairpersons for multiple CMEs and training programs at Max Hospital and faculty at undergrad conferences. I welcome you, Dr. Niranjani. We have with us our second speaker, Dr. Harshal Gayadhane, who is an emergency physician at Wokhad Hospital. He is dedicated emergency medicine physician focused on delivering evidence-based care in acute, high-pressure clinical settings. He has completed his DNB in emergency medicine in 2025 from Paras HMRI Hospital, Patna, and did his MBBS in 2020 from Government Medical College, Yavatmal. He has a good hands-on experience through rotational internship and emergency medicine training, managing diverse medical, surgical, and trauma cases. He is very skilled in critical procedures, including airway management, trauma resuscitations, critical or central or arterial line insertion, intubation, ICD insertion, lumbar punctures, and ventilator management. He is very proficient in point of care ultrasound, lung ultrasounds, and emergency diagnostic. He is certified in various acute neuro cases care and trained in airway management and advanced trauma care. He has strong competencies in triage optimization, reducing ER wait time, and team leadership and coordinated patient care. I welcome you, Dr. Harshal.
Thank you.
Now I request our the post director and moderator for the session, Dr. Rupesh, to just give the context for the session and start with the session. Dr. Rupesh.
Hello. Yes.
Yeah. So you can just give the context for the session and go ahead with it.
Yeah. So, thanks, Dr. Minal. So, welcome, Dr. Niranjani and Dr. Harshal, sir. Okay, so today's topic, I think this meeting will be recorded and they will be forwarded to other residents also. So,
Yes, sir.
this is the agenda for this is how the emergency medicine department deals with the emergency cases of acute stroke, maybe ischemic, maybe hemorrhagic, or other forms also, including the stroke mimics. So, how to identify it? What are the timelines to manage it? What are the modalities, including interventional neurologist, how they are helping, and what is the team approach? How code stroke is been implemented in a tertiary care center where all the cath labs, where a neurologist, neurosurgeon, and functional emergency medicine department makes the difference between life, death, and disability. Over to you, Minal.
So we can start with our first speaker.
Dr. Harshal, would you present your case first?
Just please tell me how to share my screen. I'm not able to find
So
it.
below, if you see, there would be an option in green color, share screen, just besides AI Companion and React.
Okay. Can you share my slides? I think you have my presentation.
Just a second, sir.
Because I'm not finding my that option here.
Uh, just a second. So I think your slide was very heavy and I think it couldn't be shared in mail.
Exactly.
So we do not
Wait,
have
because
it with us currently.
I am
So
using
right
iPad. That's
besides
why.
the React option, there will be the share button. RX events, can you guide with iOS what is the system?
Sir, you can see, are you using a browser or in a,
I'm using a browser.
okay, you are using a browser, you can see there is a share button in the downside.
Downside, there is no share button.
Okay. I
Uh,
think
should I come with the app?
you can join with the app. It's quite easy with that.
Okay, I'll just rejoin you guys. Please wait for a while.
Sure. Is it okay if till then we continue with Dr. Niranjani? Dr. Niranjani, would you please present your case until then, if that's okay?
Yeah, sure. Not an issue.
Thank you, ma'am.
Yeah. So, is it all visible?
Yeah, it's visible.
Okay. So, good evening to one and all. And I thank Gennova, Dr. Rupesh Bokade, and all the people involved in this webinar to give me this opportunity in talking about the stroke cases and discussing developments and role of emergency department per se in management of stroke cases. So today I am with a case series of 3 patients which we have recently seen in our hospital. And they presented with stroke and an acute cardiac event. So that's why my heading goes like clot conflict and the time clock. Management of concurrent MI and stroke. So the first case is of a 37-year-old male who came to the ER with complaints of retrosternal burning since 2 to 3 days, associated with one episode of vomiting, worsening symptoms on the day of arrival. So he was apparently normal. According to the history, it all looked like a cardiac event. So here are his vitals, which were all completely stable with a GCS of 15/15, random blood sugars of 200 mg per dl. Primary survey was completely normal, completely acceptable limits, no need of resuscitation. We go with the primary survey adjuncts, and this was his ECG. Very clearly evident that it's an inferior wall MI. So we called for a code STEMI in our hospital according to the protocol. Around 9:54 a.m. was the code STEMI. We took in for 2 large Bose cannula. Basic labs were drawn. The patient was given loading doses, and we were preparing for the primary PCI versus IV thrombolysis. In the meantime, when we were preparing for this, the patient suddenly developed an acute altered mental status with a deteriorating GCS of E2M4V2 and a new onset, completely acute onset right hemiparesis just right in front of our eyes. We immediately intubated him in view of threatened airway and then took him for an MRI, which suggested an acute ischemic large left MCA infarct. So here's what we did. We have a code STEMI and code stroke protocol in place. So we announced for the codes. We did a multidisciplinary intervention. Cardiology and neurology was consulted simultaneously. All the relatives were counseled for all the risks, benefits, etc. and the need for the IV thrombolysis in such cases. And we thrombolized this patient with 14 mg of tenecteplase after due consent. So after all this, the patient was shifted to ICU for the further management. Here is his MRI, which clearly states that there is a large left MCA infarct. This is his post-thrombolysis sequential radiology. Post-thrombolysis, he developed a hemorrhagic conversion of the infarct, due to which he had to be taken up for a decompressive craniotomy. As hospital is a super specialty hospital with a neurosurgery inbuilt team, so we urgently took him for a decompressive craniotomy. Eventually, the patient went on track. He was decannulated after day 6 of track and gradually improved in his GCS clinical status, and eventually he was discharged out of the hospital. Another case that I would like to discuss is a 66-year-old male that came to the ER with aphasia and left-sided weakness since 1 hour, well within a golden period, well within our thrombolysis window. Last seen normal after getting home when he went up for freshening, and he was a known case of diabetes and hypertension on medications. So here are his vitals, again suggesting completely normal vitals, hemodynamic stability, random blood sugars were ruled out, 146. GCS was 15/15 on the initial setup. His primary survey was completely fine. Only about the disability, he had a power of 0/5 on both left upper and lower limb with aphasia. Then we went ahead as per our protocol to get an ECG in such patients, and we saw this. So on this ECG also, we again see an inferior MI with ongoing progressing to a complete heart block kind of scenario. So on seeing this on the ECG, we immediately started to give him loading medications, but until our loading medications went to him, he completely deteriorated. His GCS dropped to E3M4V2. He developed a bradycardia and a complete heart block event. Immediately, he was managed according to the ACLS protocols, taken on transcutaneous pacing, and an inotropic support simultaneously, and the patient was resuscitated. Again, we had to intubate him in view of low GCS. And as in this scenario, he had an acute cardiac event, which was quite major, and we couldn't take him for MRI. We did an CT brain, which showed no hemorrhagic transformations. So we decided to thrombolyze him. But this time, again, a multidisciplinary intervention was done. Cardiology and neurology was consulted. all the consultants, all the multidisciplinary team took a decision to thrombolize this patient with a higher cardiac dose, that is 30 mg of IV tenecteplase, with due consent and after explaining all the pros and cons of the procedures. After thrombolysis, he was also shifted to ICU for further management, but he still was in a very critical condition because of his cardiac shock and an ACS which had very bad EF and no supporting diastolic. He was on multiple inotropic supports immediately when we shifted him from the ER. So here also we had to announce two codes simultaneously. Within 3 minutes, we had two codes announced, and we could manage this patient, I think, within 45 minutes, he was completely resuscitated with all the investigations done, thrombolized, and then shifted to the ICU within 1.5 hours. So this was on, but this patient actually, the second patient progressed in a not in a good way because of his cardiac status. We couldn't resuscitate him within 24 hours. He went deteriorated on his hemodynamic status. His cardiac status more deteriorated, and his inotropic requirements increased. He was even taken up upon transvenous pacing, but still we couldn't resuscitate him. He had two code blue events, and in the second code blue event, he couldn't be resuscitated and had to be declared dead. Another interesting, similar case, a 59-year-old male came to the emergency with chest pain, headache, dysarthria since 1 hour. This was a mixed picture at the initial presentation itself. He was a type 2 diabetic on medications. So his vital signs and primary survey was normal, except for the disability that he had was a dysarthria. Again, when we did his ECG revealed something else that was going on, and it was again an inferior wall MI with a inferolateral wall MI actually, and we had to announce two simultaneous codes, code STEMI and code stroke both. Again, a multidisciplinary intervention was done for this patient. This patient, as he was complaining of headache and also had an ACS event, though hemodynamically he was completely stable, we took PCI as the option for this patient. He, after counseling and after understanding all the things, we took him up for PCI. He was taken up for primary PCI, shifted to the cath lab, and on way to the cath lab, a CT brain was done, which showed no acute hemorrhage. So the patient was given loading doses also. And after stabilization, post PCI, after his cardiac stabilization, when we did an MRI, it showed a very small pontine lacunar infarct. At presentation, this patient's NIHSS was around 4 to 5. And that was the reason we decided to save the heart first and do an intravascular thrombolysis, which we generally do, and take up with a heparin infusion and do a thrombolysis in that way and revascularize the brain also simultaneously. So this patient also responded very well. He showed gradual improvement and stabilization, gradually improved in his status, and eventually he was also discharged from the hospital. More two such cases recently had come, which had similar presentations, which had multiple embolic episodes. So nowadays, with a rise in this event and these kind of episodes, you can clearly see that a multidisciplinary approach is required for these kind of patients. So my points of discussion today by bringing up this case series was how to approach such patients in the emergency. What is the mechanism of cardiocerebral infarction? And the drug of choice for IV thrombolysis, and should it be cardiac versus the neurodose? What does the guideline says about this? And is rescue PCI indication? And if it is an indication, in which subset of the patients do we take them for PCI? So, as I said, the mechanism of simultaneous occurrence of the cardiocerebral infarction can be any of the following. There can be a simultaneous thrombosis of the coronary or the cerebral artery, such as in atrial fibrillation patients or type 1 aortic dissection, which involves a common carotid artery, or an electrical injury per se. So, any such history should instigate an emergency physician to think of that we can land up into a simultaneous thrombosis of cardiac and cerebral event. Stroke can be caused by any of the heart diseases such as interventricular thrombosis, patent foramina ovale, that is complicated by right ventricular infarction, and cardiac shock after the acute myocardial event. the cerebral cardiac axis generally is disturbed in such events, and that can lead to myocardial injury. Basically, when the insular cortex is involved, insular cortex is generally involved in regulation of the central autonomic system. And when insular cortex is involved in an acute ischemic stroke, this interrupts a lot of circadian rhythms for the BP, causes a lot of myocardial injury, and it is related to disruption of the sympathetic nervous system. So how do we manage such patients? As I said, and as I've focused, as I've showed you, in our hospital, we have a multidisciplinary team approach. We have code stroke, code STEMI going up, and all these things help managing such patients effectively and at a very earlier stage, improving the outcomes. So, prioritization on the stability is generally because if the patient is stable, then we can prioritize treating the stroke and take up for the IV thrombolysis or intervention that are treating stroke initially. But for unstable patients who have STEMI or who have cardiac shock, the cardiac condition is immediately life-threatening, and that needs to be prioritized over the stroke treatment. That is what our multiple research, multiple case reports that have been published on the same cases have shown, that revascularized strategy should always be a combined approach. The most favorable outcomes that have been shown in such cases are seen with a combined mechanical thrombectomy and a PCI for the AMI. If the facility doesn't have these specialized therapies, they can even choose for an endovascular catheter-directed delivery of intracardiac and intraarterial thrombolysis, which can be safe and effective in these subset of patients. Recent literature also suggests that a sequence of primary coronary intervention followed by mechanical thrombectomy or the vice versa should be tailored patient to patient and not a basic guideline per se that this has to be done first or that has to be done later. Dual antiplatelets, which has to be started, can be started at a later stage around 48 to 72 hours, which reduces the post thrombolysis ICH risk, the intracerebral hemorrhage risk. So the key clinical pearls that we get to understand through these case series is that we need to first exclude aortic dissection by a basic bedside echo, which was done in all the three cases. Full dose lysis for STEMI that we do with 100 mg or a higher dose is generally avoided because of his risk of intracranial hemorrhage. And other clinical consideration that I have already mentioned earlier also, that if it is a right insular involvement, always suspect a high mortality and a higher risk for strokes and sudden cardiac death. And many case reports, also the three cases that I have shared, you can even see a higher incidence of these cardiocerebral infarction with inferior wall or inferoposterior wall MIs. So whenever there is an inferior wall MI or an inferoposterior wall MI, you should always have an anticipation of this, either concomitantly that a stroke can happen like it had happened in all these three cases, or it can be a event that follows within 24 to 48 hours. The risk factors for vice versa events are almost 2 to 4% each. So these are my references from which I have stated all the guidelines and the treatment methodologies. And yeah, thank you. This is the feedback QR code that you all can scan to give a feedback. And I'm now open to questions.
Yeah, excellent presentation, Dr. Niranjani.
Thank you.
So, and very insightful actually. These are the cases when it comes to the real life. So, which organ takes the priority, whether it is a brain or the heart, and that is a dilemma. Is always it is that key. Which has to be taken? Do we need to treat the heart first or the brain first? So, as you rightly mentioned, if the patient is hemodynamically unstable and heart is crashing, whether it is a cardiogenic shock, malignant arrhythmias are there, definitely go for immediate primary PCI.
Thank you.
That should be there because we have to save the life of the patient first.
Yes.
And maybe if there is not a bleeding or if there is a ischemic stroke, then we can give the antiplatelet even without thrombolizing such patient. But definitely the immediate primary PCI takes the priority
Priority.
first. And if both are present and the patient is stable, then definitely go for IV thrombolysis. In such cases, maybe altiplase can be a safest option, I think. But definitely both are approved
Yes,
drugs,
yes.
so we can go along with the these things
So the
also.
guidelines also say the same thing. IV altiplase as at a dose of stroke.
Yes.
IV altiplase can be given at the dose of stroke, that is 0.9 mg per kg that we load the patient at the stroke
Yeah.
thrombolysis dosage. It can be given in such concomitant events, or also we can use tenectase. Tenectase has also shown a better outcome and better lower incidence of complications in many such case reports.
Yes. So yes, that is the IV thrombolysis with altiplase plus mechanical thrombectomy can be there in the can be done if the patient is stable. So excellent cases, definitely. And we came across such cases with the acute EMI. Mostly such cases are type of cardiomyopathic stroke. So many of the times, one of the thrombus went into the this thing, the circulation, the brain circulation, and maybe some arrhythmias, underlying arrhythmias, or atrial flutter or fibrillation can definitely send one of the thrombus into the brain. So
We had one more such case, which was it was a triple thrombotic event: stroke,
mm,
acute myocardial infarction, and a peripheral limb ischemia,
yeah,
acute limb ischemia.
okay. Okay, so that is maybe the thromboembolic event only.
No, that
Both the
was because of aortic dissection. That was associated with aortic
Acha,
dissection.
aortic dissection.
Yeah, yeah. That to type B, it
There
needed a
might be type
surgery.
B.
Yes,
Yeah, so it is a surgical management purely. Yeah,
yes.
excellent, excellent.
Thank you, sir. Thanks a lot.
Yeah. Any questions in the chat, Dr. Minal?
Kalpita, could you see any chat, any
So,
questions?
no, currently there are no questions from the
Let's
audience.
move to the
The
next
audience have
topic.
joined from a separate link. So we
Yeah.
have a separate delegate link which was shared on the invite,
Yes.
and on this
Yes.
particular link, it's only the faculty members.
Yeah.
So
Yeah.
there is an option for questions as well, but currently there are no questions.
So can you move to the next?
Yeah.
Sure, sure, sir.
So let's welcome Dr. Harshal sir. He is going to
I hope my screen is visible. Is it?
No, sir, it was
No?
visible earlier. Now it's not visible.
Okay, wait for a while.
Yes, sir, it's visible now, but we cannot see your presentation.
Okay, wait.
Yes, sir, now it's visible.
Okay.
Perfectly visible.
So, thank you. So this was a story of 76-year-old male. He brought to ER on 8th of April 2026 at around morning 9:30 a.m. He gave a history from its relative. We got to know that patient was having a episode of seizure 2 hours back, followed by the episode of drowsiness. So typically, whenever the patient comes with the history of seizure, the patient is in drowsy state, or we can call it as a postictal phase. So uh, I just did an initial assessment. So it was the airway was patent, the breathing was normal. Around SpO2 patient was maintaining its saturation. There was no as such abnormal findings in circulation as well. By the time when I went for to check a GCS, I got a E2 V2 M5. And what was the main observation at that time was while checking GCS, when I give a painful stimuli, his right side of body was not responding well. So at that time, I thought it might be the stroke as well, or the Todd's palsy, what we call it in after. Sorry, am I able to Is it visible?
The slides are not
presentation.
visible.
No, slides are
Oh,
not
sorry, sorry.
visible,
Ha,
Harshu
ha,
sir.
ha. Okay.
Yeah, now visible.
Ha,
Yeah.
ha. So at that point, first we loaded the patient with the 1 gram of levetiracetam, and we announced the code stroke. So for the adjunct primary, we did a ABG just to see the lactate levels as it is increasing in stroke patient. So after this, we come to the conclusion of differential diagnosis. It can be a seizure with postictal paralysis. It could be a stroke. It could be a dyselectrolytemia or SOL or meningitis as well. So sorry, sir. Just while so I will just enumerate the all the scenario here. When we announce the code stroke, uh, patient had a history of ecosprin. Like he was on ecosprin. He had a episode of a CAD 2 years back, and he was on ecosprin, telmisartan, atorvastatin. So we also thought that patient might have the intracranial bleed as well. So anyway, we went up for the code stroke and we did a MRI. And for MRI, we got the uh, parietal stroke, which was in acute ischemic stroke. So what are the hurdles that I got in this case was particularly the NIHS score. So what we got, the score was a 22. But what is the problem here? The NIHS cannot differentiate stroke from stroke meanings like total paralysis and measures severity of a deficient, not etiology. It measures the severity and not the etiology. So there is a risk of overdiagnosing stroke and unnecessary thrombolysis. Like the hemiparesis in NIHS interpretation, we take it as a high motor score, but actual the cause is the total palsy. Also for the aphasia, it has a high language score, but the postictal aphasia could be there. Similarly, for the altered sensorium, there is a high LOC score, but it could be the postictal confusion as well. So these are the hurdles that we get in NIHS score while evaluating such patients. So at the time of NIHS score, there was few highlights. So first one is the best guess. So in this patient, I would like to enumerate some basic things from Tintinallis. So it has to be checked with the oculocephalic reflex. Also for the visual fields, I had to use a blink to thread test in all quadrant to measure to evaluate the visual fields. Also for limb ataxia, it was untested, and in extension and inattention, it was a 2. So as you can see, the stroke was announced. So there was a parietal acute ischemic stroke, as you can see on diffusion and ADC. Um, then, since the patient was in window period, the history was just before 2 hours. So we decided that we will try to thrombolyze this patient, and there was no uh, contraindication to thrombolyze this patient. The only thing was the patient was on ecosprin. So there was a dilemma that what should be the dose. So the first thing was in my mind is whether the single antiplatelet drug will increase the chance of intracranial hemorrhage after thrombosis. With the consultation with the neurologist, Dr. Ankur Jain said, so we decided to go for the dose of 0.2 mg per kg, and we did thrombolyze that patient with the 18 mg of tenecteplase. For this, our door to MRI time was 20 minutes, door to needle time was 53 minutes, and our blood reports came within a 45 minutes. So we went for a thrombolysis, and that patient who was in a drowsy state, the GCS was slightly improving in the MRI itself. So at the 15 minutes of thrombolysis, GCS was improved very well. Like it was before E2, V2, M4, and right now it is E3, V4, and M6. As you can see, the power was also well maintained on left side and right side. Vitals were still stable. So if you can see, this was the CT angio in the cath lab that we did in this patient. We can see there is a right RCA, right carotid artery is fully stenosed. So the it was carotid stenting was done by Dr. Amit Bhatti. So you can see the recanalization and distal protection device in this video. I hope I am able to visualize all these videos. Am I right?
Yes, sir.
So we got the good recanalization of this carotid artery as well. Condition on discharge was very good. We got the NIHS score 0 with the stable vitals. So what are the recommendation and what are the difficulties? What we got in this case was in early seizure, we within a 7 days we use short-term anti-seizure measures, and it is around 1 to 4 weeks. And for late seizure presentation, there is a high recurrence, so we use a long term of anti-seizure medication. So primary prophylaxis is not recommended in any of the stroke which is acute unless and until it's a late seizure. So it is also supported by AHA and ESO. The most important thing was the dosing, because it is a worldwide debate, I think, because in Indian scenario we mostly using zero point 0.2 mg per kg, and in other countries like AHA they have uh, presented the dose of tenecteplase with the 0.25 mg per kg. But since this patient was on single platelet and single antiplatelet drug, we went for a zero point 0.2 mg per kg. So studies like ACT2 trials, TRACE2 trials, and ATTEST trial, they compare tenecteplase 0.25 mg per kg with the alteplase in acute stroke, and they found that tenecteplase was not non-inferior for 90-day outcome with the similar safety. The safety profile for tenecteplase and alteplase, they found it the similar way. Single antiplatelet drugs uh, slightly increases intracranial hemorrhage, but it is still acceptable, and we still recommend that we should thrombolyze those patients. Even for the dual antiplatelet drugs, there is a higher chances than single platelet, but still overall benefit is preserved. So in this case as well, if the patient is on dual antiplatelet therapy, we also go for a thrombolysis. Uh, this 0.2 mg per kg dose is usually preferred in India. Even in my hospital, I used to thrombolyze with the 0.25 mg as with the consult with the neurologist. But in this case, sir was so stubborn with the 0.25 2 mg per kg that he didn't allow me to go for 0.25 mg, and I was quite comfortable with that as well. There are two trials, that is a TRACE-3 trial and extend tenecteplase trials. So in TRACE-3 trial, it evaluate the tenecteplase in wake-up stroke. So this study is being done for time period to increase up to 9 hours. 9 hours. So we are hoping this trial will get a good outcome so that it will be more helpful to thrombolyze patient up to 9 hours. Then extend, it is also the based on the imaging, the salvageable area of the brain as per the MRI and reperfusion studies. So these are the two studies that is very helpful. The conclusion of this case is the stroke and stroke mimics can occur together. Usually we learn about the stroke mimics and we say that this is a stroke mimics. But in this case, there was both cases was involved, like stroke and stroke mimics. Seizure is not a contraindication for thrombolysis. Antiplatelet not contraindication for thrombolysis, though there is a slight increase in ICH. Also, tenecteplase can be preferred over alteplase, and dose for tenecteplase 0.2 mg, 0.20 mg per kg or 0.25 mg kg is a real dilemma one should use with the consulting neurologist. So this was this was the case of mine. Thanks for listening, and sorry for the disturbance in all my PPT. please, Dr. Rupesh sir and Dr. Niranjani ma'am, please have your opinions on this case.
Yeah. Excellent presentation, Doctor. Niranjani, madam, do you have any take on this?
Uh, I just wanted to say that we actually use Rozier's and Faber's scale in case we suspect that it might be a stroke mimic.
Yes,
It
ma'am.
just, as you said, that we can avoid unnecessary thrombolysis, but this case actually had a infarct on the MRI. And
Yeah, yeah,
always, whenever there is a facility available in such dicey cases where we are in a dilemma, if it is a stroke, proper pure acute stroke, or is it a mimic, I would always suggest, and also the guidelines also say that we should go with a MRI imaging rather than a
yeah,
CT
yeah,
based
yeah,
decision.
yeah, right, right.
That's it. Otherwise, it was a very good case, Harshad.
Thank you, ma'am.
Yeah. So there are now even the recent guidelines suggest that thrombolysis window can be expanded. In
Yeah,
selected case, they have expanded up to 24 hours as well, including the what we can say interventions as well. So what is the thing if the patient come after 4.5 hours? So what is the protocol there, Harshal, at your place? How do you?
sir, we go for a mechanical thrombectomy if
Yes.
there is a chance to do it, because
Yeah.
here the perfusion. I just joined here, so I don't know whether they are performing perfusion studies or not. But yes,
They are
we go
doing.
for.
Even Dr.
Uh,
Amit and Dr. Ankur sir,
uh,
they do
but.
perfusion studies sometime, depending on the
Uh,
patient to patient.
uh, uh, Yes, sir. We do the patient to patient, but most of the time, as I came across this 2 3 months, it
Yeah.
is like if the patient is presenting after 4.5 hours,
Hmm.
then we go for mechanical thrombectomy if the patient is eligible.
Yeah.
Hmm.
So that is the thing. Even now, the recent guidelines suggest give door to groin time thrombectomy
Uh,
for thrombectomy should be less than 30 minutes also.
30
So
minutes.
definitely, sometime they want uh, to do the perfusion studies as well.
Yes, sir.
That is the thing, Babas. I just want to.
Sir,
I was
what
thinking about why the
I want to ask
ABG
you,
was
sir.
done at your case. Why the ABG generally we avoid ABG or the arterial puncture.
Sir,
Uh,
it is before.
because
It was before thrombolysis. So.
yeah, even in the stroke patient, there are
Hmm.
only three things we are supposed to do. Just check the vitals, do the primary survey, do the sugar,
Yeah,
and
yeah, sure.
ECG. That
Mhm.
are the things. These are three things
Mm.
we just wanted to
But
do.
yes, sir, definitely. Since this patient was presented with this seizure, uh, that's why we did it. Otherwise, we don't do it in usual cases. I
Mhm.
would like to ask you one thing about the doses of tenecteplase. Sir, what do we should follow AHA guideline strictly, or we should include these Indian studies as well for zero point 0.2 mg per kg?
Okay, okay. For that thing, yeah, the meta-analysis, the recent
Ah,
meta-analysis suggests that 0.25
yes,
dose
yes.
can be considered.
Mhm.
Yeah, the recent updates.
Thank you, sir.
Yes, yes. So, Kalpana,
So, any other
anything else?
questions?
Any other questions? Or
No, so currently there are no questions from the audience. There is just one question, as I think Dr. Niranjani had mentioned that the Rosier scale is usually used in cases of stroke mimics. So, is
Hmm.
there any particular reason for the same?
The Rosier's and the Faber scale actually differentiate your the parameters that is it has. It generally differentiates from stroke mimics. So if your scale has a low score on Rosier's is for basically for the, and Faber's and telemimic stroke scores. These are three scores that we use to differentiate stroke mimics and acute pure strokes. So they have a clinical cutoffs that if the score is less than 2 or if the score is more than 3, it is more likely to be a stroke mimic.
Okay. Sure, ma'am. I think that was the only question. So, thank you so much to all the three doctors. I think the cases that were presented were fantastic and very interesting, rather. And I think all the points that were covered were very well highlighted. So, from the entire team Gennova, I would like to extend a warm thanks to all of you, Dr. Rupesh Bokde, Dr. Niranjani, and Dr. Harshal, for your valuable time. And we hope to have you often in our session so that you can share more of these interesting cases. I think from the emergency perspective, it was a very new perspective that was shared, and the emergency was highlighted quite well, like how it is different in this department as compared to the neuro department. So I think that urgency was depicted very well, and I think from the entire team Genova, I'm very grateful for your time in this for this event. So thank you so much, and we hope to see you again soon. Thank you so much, all the doctors.
Thank you. Thank you for giving us
Thank
the
you.
opportunity.
Thank
Thank
you
you
for
so
giving us this opportunity.
Thank
Thank
you.
you.
Thank
Thank you,
thank
sir.
you.